When you look at the level of implementation, I have to recognize that since we started using the cone beam CT technology, the DICOM file, we reduced the radiation for the patients. They are commonly accepted. Most of you or some specialists may have it in the office or not. It allowed us to get the data acquisition digitally from the radiographic viewpoint. And as you can see here, this patient is taking, is being exposed to the three-dimensional imaging with the reference of the future prosthesis in relation to the anatomy of that patient. And I say that particularly at the beginning because this is kind of like a general perception that you see the patient, you are planning for implants, the immediate next step is to take a cone beam CT. And I don't think that that's the right workflow. Cone beam CT will come at the moment when you have done your prosthetic planning. And I give you an example. If you take a cone beam CT on an edentulous patient without any prosthetic referencing, that cone beam CT will be of very little use. Or you will be guessing on the implant position, right? So, and I will address that in a moment. Then we learn how to superimpose an STL file from a digital impression with a DICOM file from the cone beam CT. And here you see in blue, this is an STL file that we obtained from a digital impression. And on the red side, this is a DICOM file. What we are doing now is a matching of the two files by selecting a known area, typically the buccal cusp of the molars and premolars. You want to have 4 of those minimum to equilibrate to balance the matching mechanism. And then you can see the 4 selected points. And now you have these 2 elements or these 2 files that they have been superimposed in that digital fashion. Why is this important? Because this superimposition here or matching of the files will allow you with the bottom with a click fabricate your surgical guide. So this is why it's really important. It's not just to see the relationship between the soft tissue and the bone. And here you have a very nice picture, the planning of the prosthesis, the teeth, the bone, and added in this green color, the outline of the situation intraorally. Now, I always comment that I placed my first implant in 1994. The only patient at that time who really accepted doing an implant with me was my grandfather. And in order to know the bone, I did a bone mapping. Do you all know what the bone mapping is? We were sectioning the model, then with an endofile, measuring the thickness of the soft tissue to have an idea of what this bone would look like. Nowadays, you can have not only this information three-dimensionally, but you can have a surgical cut where you can have the prosthetic planning, the bone structure, and the soft tissue line in relation to your planning. And when I look at this compared to my 1996 bone mapping, I am really happy to report that we have made progress. This is exactly something that we all somehow need to recognize that is good for our profession.